Next, we will hear from Dr. Kelli Tice, who is a family physician with a background in public health, who serves as Guidewell and Florida Blue's Vice President of Medical Affairs and Chief Health Equity Officer. In this role, Dr. Tice is responsible for creating solutions that improve health outcomes and address health inequities for Guidewell's customers and communities. In addition to leading the company's health equity strategy, she has responsibilities in the areas of corporate social responsibility and public health surveillance. We're so grateful Dr. Tice is with us today to share more about Florida Blue's efforts on long COVID.
Thank you. I am very glad to be here and have the opportunity to participate in today's conversation. I think Dr. Koroshetz has really illustrated that there is much yet to be learned about this condition, and certainly I'm pleased to have the chance to share from a payer perspective. The truth is, where long COVID is concerned, there are still a great many unknowns, and from a payer perspective, we are uniquely positioned to see impacts across the healthcare continuum, but we are also uniquely disadvantaged because of the, sometimes the lag in data and the lack of insight we might have into how things are being managed, decided, considered, for instance, at the provider level. But these are good problems to have because it has forced us to be innovative in terms of our solutioning. Next slide. Next slide. You may be familiar with Florida Blue as the health insurance arm of Guidewell Mutual Holdings Corporation. And that, in fact, is somewhat of a parent company, and we consider ourselves a health solutions company. We are a nonprofit. And while the insurance arm covers, almost 6 million lives across every county in the state of Florida, our footprint as a company is actually much larger than that, now serving 46 million people in 45 states, including Puerto Rico and the U.S. Virgin Islands. Point out our recent acquisition of Triple S is giving us an opportunity to be involved in and direct the care of a number of people on the island of Puerto Rico, which further expands, in particular, our efforts to ensure and promote health equity. Next slide. So I wanted to start with a review of how we framed and shaped our response to COVID-19 in general. In fact, it was very early in the pandemic that once we had moved our then some 10,000 or so employees into remote status, that we began to focus intently on what our role as a payer needed to be in terms of supporting our members, as well as being having positive influence in our communities. On the left side, you see our areas of focus, and we met challenges, significant challenges on that side of things. One, we were working very hard to keep up with data that was sparse initially, that was difficult to validate. And certainly there was a significant delay until we were able to leverage claims data in any sort of meaningful way. We, in the interim, really relied on partners, providers, hospitals, and even public health officials to ensure a good flow of validated data into our system so that we could determine what needed to be done, where, and how. We worked very, very diligently on not just creating messaging, but evolving that messaging as information changed, and being really particular about how that messaging was being targeted to the audiences that were at risk. We used our partnerships with community organizations, both on the nonprofit side, public side, as well as in the private sector, at the local level, at the state level, and at the national level, to ensure that we could we had contact with and connection to thought leaders who were trusted by various areas of the community. And then, of course, we tapped out on every bit of clinical expertise we have within our organization in order to track what was a rapidly changing pandemic. we moved through several phases. You know, it talked about information, and then as soon as testing was available, vetting and validating the accuracy of testing, ensuring that it was available in an equitable fashion. We actually were members of a White House task force that was developed to ensure equitable vaccine distribution. And well ahead of vaccine distribution, we recognized that there was an opportunity for us to use our relationships with minority serving organizations and institutions to build ahead in advance of vaccine distribution the messaging and the relationships necessary to deliver both information and vaccines to those at-risk communities. We also very quickly identified in our own member population who was at risk and how they needed to be managed in order to reduce that risk. And that focus has really continued throughout the response. Each time there was an uptick in cases, we were brought sort of back to the drawing board in terms of how we needed to refine our approach to ensure that we were still having the appropriate impact. Next slide. This is the best example, best visual I could provide you in terms of our approach. This happens to be what we used as we worked to distribute vaccine equitably, but we have applied this model throughout the pandemic, and in fact continue to leverage it for our overall vaccine strategy, as well as our public health and health equity efforts. So what you see is a map that is generated out of a social determinants of health dashboard that we created really very early in the pandemic, that allows us to identify by community social vulnerability levels. We were able to map where our member population is within the geographic areas. We can also place on the map key partners, for instance. So you see here our floatable retail centers, which become our clinical hubs in our communities and allow us to deliver services to the community out of sort of a storefront. In this particular map, we also mapped faith-based partnerships, which became key relationships that we leveraged for some of our vaccine events. This was the tool that we used to determine where we were going to allocate resources, with whom we were going to partner. Frankly, what we said yes to in order to ensure that we were being good stewards of the resources that we had in order to contribute to some of the solutions that were necessary. And we have, again, leveraged this over and over again through the pandemic, with each iteration in order to be sure that we are meeting our members who have the greatest and highest needs. Next slide. Dr. Korsich talked about the vast array of symptoms that folks with long COVID symptoms can develop, and we certainly wrestled with this very early on. There wasn't a code for long COVID for some time after we knew that post-acute sequelae of COVID was even a thing. And we began to really pour through what we were seeing in our claims data to try to understand what the experience was of our members related to this. Initially, we had only anecdotal reports. Because we were very intentional about gathering information from our members through all of the available touch points, one of the first sources of information for us was survey responses that we got at the end of the more than 30 COVID webinars that we did starting in mid-2020. At the end of each of those webinars, as soon as we knew that post-acute sequelae of COVID was a condition for which we needed to be concerned, we would actually deploy a few questions out to all of our webinar participants and registrants, asking if they themselves were experiencing such symptoms. And we actually got quite a bit of rich data. We couldn't necessarily string all of those symptoms together right away, but we certainly knew that what we were hearing and seeing reported across the country was an issue for a number of our members. You see there the definitions that we used, and we actually, the data I'll show, which is really directional. There are a number of reasons that our data still is somewhat inaccurate. But we use both suspected and confirmed, because we know that there's a learning curve in the provider community in particular And what we're finding is that very often members are being seen multiple times before a diagnosis of long COVID is actually being applied. And in order for us to understand real impacts, then we have to be able to sort of look back and identify it in our claims, often even before the member begins to carry a diagnosis. It's critical that also that we understand that there are neurologic impacts, cardiovascular, pulmonary, behavioral health impacts, and so being able to characterize this in detail becomes incredibly challenging. Next slide. I think in correlation with what has been seen, what has been presented already, we're seeing a higher prevalence in females in our claims, as well as those with chronic conditions. In fact, the prevalence for those with chronic conditions is actually more than double those without. We also see a higher prevalence in our members who are over the age of 40, and definitely we see a correlation with those that are living in areas of high social deprivation. Catherine, in her introductory remarks, actually spoke about the disparities that are of concern when we talk about COVID infection in general, and those same risk factors for disparate impacts exist for long COVID as well. Next slide. I'll take you through some of this data again. With a grain of salt, we have to take some of these, but I want to point out a couple of things. You see the increasing frequency of suspected or long COVID, or confirmed long COVID as age increases, but if you look there at the younger population, this correlates with some of the impacts that we were hearing from our parents of some of our youngest members early in the pandemic as well. Next slide. I mentioned that chronic conditions were an issue, and in the table here you see the vast increase in the prevalence of long COVID in our members with more than one chronic condition. It is incredibly significant, and this actually aligns with what we saw with COVID hospitalizations. And perhaps it is then good to note that using our approach in terms of identifying and risk stratifying our members, we were already doing proactive outreach to many of these members because we recognized that their chronic conditions placed them at risk for COVID. And then we determined that it also increased their risk of long COVID symptoms. Now, just wanted to talk a little bit further about our data challenges. They have been significant, and as most payers have, we have found a need to reside somewhere between what is validated and publicly available, study proven, but not specific to our members, and what we can gather from our own member population. We've got to do a number of things. First and foremost, we have to protect our own members, which in many cases is our own employees, our own team members as well. So any learnings that we can gain from any source certainly is useful. But we also need to be able to predict the impact of long COVID on costs. And while these current data on this is somewhat directionally accurate only, we are seeing a significant increase in member costs for those who have a history of having been infected and dealt with COVID. In fact, thousands of dollars in most cases of additional costs in the months that follow that diagnosis. And so that's certainly something to pay attention to. We'll talk further about the other economic impacts of long COVID. But one of the reasons that that's a great concern is because in a system where we know access is an issue, those costs can be more significant if we are worried about access, if we're dealing with providers who, for instance, who aren't sure of the appropriate way to evaluate these conditions. And what we're finding, in fact, is that many of them are ordering everything in order to be certain that they don't miss anything. Which can be, a rather inefficient way to utilize resources. One of the other things that we attempted to do early on, and we are continuing to make a part of our support of our members, is to stay abreast of the COVID centers of excellence that have been developed in our state, so that we can direct members to those services, understanding, as soon as I say that, the difficulty and challenges that exist when you have, four or five kind of core areas in the state where you've got expertise, and other areas of the state that may be uncovered from a clinical professional standpoint. Next slide. When we think about our members and understanding their impacts, I mentioned that as soon as we thought long COVID might have been a thing, we began gathering information. The other thing that we did fairly quickly was to pull our team together and map the journey of a member who had COVID and subsequently developed long-term symptoms. That allowed us to see all along the care continuum where the opportunities were and where the needs for support existed. We were able to leverage information that we gathered from our own contact tracing efforts for our employee population in order to understand the implications of the condition, as well as the limitations of the system in terms of folks having access to information about long COVID, much less treatment and evaluation. While we gathered the information clinically, we understood a few things: that there was support that was needed, that the impact and long-term debilitation required more mental health support. We leveraged the use of our hotlines, our multidisciplinary care teams to do proactive outreach and provide that member support, help them feel heard, connected, cared about, while we learned what was happening in the clinical landscape and worked to help sort of facilitate linkage into care. We also did a number of follow-ups with members who had these experiences to better understand what it's like to navigate a system that was sort of defining itself real time. Next slide. I'm definitely very, very proud of the slide that you saw at the outset that really talks about how we leverage the data that was available to us in order to really direct and target our responses. The other thing I'm really extraordinarily proud of is our care management approach. We have long had a multidisciplinary approach to care management for our members who have highest needs in terms of chronic illness or other social barriers to health care. And we have continued to leverage those teams in order to meet the needs of our patients, our members who are identified with long COVID. Our care management teams actually exist across our state to serve our member population by geographic location. And those teams include medical directors, clinical pharmacy leaders, social workers, and nurses, and other skill sets as needed. And that is a very local approach that is present for our members. But we use the same model to actually contribute similar information and support at the community level out of our Florida Blue retail centers. Again, multidisciplinary teams, but including a social worker who is embedded, but with partnerships with local community organizations and groups, and an understanding of what's happening on the clinical side of things. What are hospital partners doing? What clinics may be opening that may be providing these targeted services, so that we can disseminate that information. The other thing that is key and that is new is that we've created a team. We identified pretty early that there is a need for someone to be tracking this changing clinical data and interpreting it and then deploying it across our internal stakeholders. And so our clinical pandemic response team still exists, I think some would say unfortunately, to ensure that as things change, the appropriate updates are made across our organization. We've got a member service center that's taking member calls. We have a sales team. We have sales agents, all of whom need to understand and be able to articulate and respond to questions. We continue to leverage them as a way to ensure that our members and community leaders have the most actionable, up-to-date information. That concludes my presentation for today. I look forward to the question and answer period, and again, I'm grateful to have the opportunity to share our perspective as a payer. Thank you.
Thank you, Dr. Tice, for highlighting GuideWell and Florida Blues leadership in supporting long COVID.